Good evening, everyone, and welcome back to the participants of previous class. On today's class on neuromuscular disorder and intensive care by Dr. Payel Bose. Before we start today's session, we would like to give a proper introduction of our faculty. Our faculty for today is Dr. Payel Bose. She is the consultant in critical care medicine department in the hospital of Medica Superspecialty Hospital, Kolkata. And her area of interests are critical care medicine and trauma management, hemodynamic monitoring techniques, and critical care imaging. Thank you.
Okay, so today's topic of discussion is neuromuscular disorders in critically ill patients. As we all know, motor weakness in a patient in the ICU may be related to either pre-existing neuromuscular disorder or a new onset or previously undiagnosed neuromuscular disorder, or because of the complications of non-neuromuscular critical illness. Whatever the cause, however, ICU admission related to such conditions generally results from respiratory muscle weakness and difficulty in swallowing with consequent aspiration. Early recognition, intervention, both are crucial. Death can result from ventilatory failure and aspiration pneumonia and the autonomic instability, which complicates some condition. Neuromuscular disorders can also complicate critical illness, thereby increasing the mechanical ventilation days and also ICU hospital stay, and it actually increases the patient's mortality and morbidity. So knowing about neuromuscular disorders in details is very, very important for managing critically ill patients. Okay, so we would be dealing with certain specific neuromuscular disorders in ICUs that we can find in our day-to-day practice. First of all, coming to myasthenia gravis. It is an autoimmune disorder caused by antibodies targeting postsynaptic nicotinic acetylcholine receptor and causes a reduction in the functional postsynaptic ACH receptor with resultant weakness. Clinically, patients present with ptosis and diplopia, limb weakness and difficulty in chewing, swallowing, and talking. Weakness typically progresses with day and worsens after exercise, difficulty in walking, sitting, or holding head erect, and also proximal muscle weakness. Most severe disease presentation occurs early in the course of the disease, usually in the first 6 months, and many patients stabilize within 3 years. Coming to the physical examination part, first, ocular muscles. Asymmetric weakness of several muscles, most commonly medial rectus, is observed, which involves both the eyes and is typically variable, fluctuating. Pupillary response is normal. Ptosis that shifts from one eye to another is pathognomonic of myasthenia gravis. Hydrophonium may improve some of the weaker muscles as well as produce improvement of asymmetric ptosis. Cold applied to the eye may improve lead ptosis. Oropharyngeal muscles, difficulty in chewing, swallowing, and maintenance of upper airway with a nasal intonation of voice, frequent choking and hoarseness of voice is observed. Limb muscles, weakness begins in limb or axial muscles in 20% of the patient. Neck flexors are weaker than extensors. Deltoid, triceps, wrist, and finger extensors and ankle dorsiflexors are more affected than the other muscle group. Thymus in myasthenia gravis. Most of the myasthenic patients have thymus gland abnormality. 70% amongst them have lymphoid follicular hyperplasia. Others have thymoma. Thymic hyperplasia produces acetylcholine receptor subunits that serve as sensitization against the acetylcholine receptors. It also expresses muscle-specific kinases, that is MASK, titin, and ryanodin receptors. Now, what are the risk factors? Age usually occurs in second and third decade of life. Later, peak in incidence occurs after 50 years. More common in women under the age of 40. It becomes more common in men older than 50 years. Associated with 20% cases of thymoma. Others association are thymic hyperplasia, autoimmune thyroid disease, rheumatoid arthritis, scleroderma, SLE. What are the drugs which causes exacerbation of myasthenic features? Antibiotics like streptomycin, kadamycin, tobramycin, gentamicin, and also polymyxins with tetracycline. Antiarrhythmics like quinidine, quinine, procainamide, local anesthetics like procaine, lidocaine, general anesthetics like ether, muscle relaxants like curare and dexamethasone, analgesics like morphine, pethidine. Now, there are lots of clinical subtypes of myasthenia gravis. Ocular subtype, they have no affinity for acetylcholine receptor antibodies associated with HLA-BW48. Usually affect treatment with neuromuscular blocking agent and corticosteroids. Trauma, status asthmaticus, organ transplantation are also associated with this. Clinical and EMG features are suggestive of myopathy. Other differentials: acute onset chronic inflammatory demyelinating neuropathy, symmetrical peripheral sensory neuropathy and weakness caused by nerve fiber demyelination. Autonomic dysfunction is not a feature of chronic inflammatory demyelinating neuropathy. In 15% of patients, there is acute onset of neuropathy. The plateau is reached within 4 weeks, similar to GB syndrome. Next is Lyme disease, caused by Borrelia burgdorferi. Neuropathic pain, facial palsy, other cranial neuropathies may be present in advanced untreated disease. Neuropathy is often more asymmetrical. Classic initial manifestation is erythema migrans, also known as bullseye rash. Next differential, acute cervical myelopathy due to transverse myelitis or cord compression. There is bilateral spinal cord dysfunction developing over approximately 4 weeks with a well-defined upper sensory level and no prior illness defining transverse myelitis or a developing compression of the spinal cord. Urinary urgency or retention. It is a typical early finding of myelopathy, which is less common in GBS. Coming to the next part, that is amyotrophic lateral sclerosis. Severe generalized muscle weakness, atrophy, and fasciculations are seen. Lower motor neuron palsy in limbs and bulbar muscles, rarely present with acute or subacute respiratory muscle weakness. Coming to the other entity, ICU-acquired weakness. So, two of the most common causes of newly acquired weakness arise in the ICU setting, also designated as ICU-acquired weakness. What are they? Critical illness myopathy, critical illness polyneuropathy. Critical illness myopathy is probably the major contributor to severe ICU-acquired weakness. Critical illness polyneuropathy affects 70 to 80% of patients with severe sepsis and multi-organ failure. Herein, we will also discuss about the causes of acute generalized weakness in ICU. What are the causes? 1. Bilateral or paramedian brainstem lesion like trauma, infection, hemorrhage, encephalitis, abscess, central pontine myelinolysis. 2. Spinal cord disorder. Again, trauma, compression, infarction, immune-mediated myelosuppression, that is transverse myelitis, and infected myelopathies, for example, by 𝑰𝒏𝒕𝒆𝒏𝒔𝒄𝒅𝒆𝒓 virus. 3. Anterior horn cell disorder, like motor neuron disease, poliomyelitis. 4. Polyradiculopathies. Examples: carcinomatous and HIV-associated. 5. Peripheral nervous disorders. Examples are GB syndrome, diabetic neuropathy, vasculitis neuropathy, critical illness polyneuropathy. 6. Neuromuscular junction disorders, myasthenia gravis, Lambert-Eaton syndrome, botulism. Muscle disorders like rhabdomyolysis, disused myopathy, infectious and inflammatory myopathies, critical illness-related myopathies. Okay, so now we would be discussing about critical illness-related myopathy. The hallmark of critical illness-related myopathy is the weakness that is typically diffuse in distribution, affecting both limb and neck muscles. Weakness tends to have a proximal predominance in the limbs, but it may also involve distal muscles profoundly. Tendon reflexes tend to be depressed but present. A serious and common complication of myopathy is failure to wean from a ventilator owing to marked weakness of the diaphragm. Critical illness myopathy accounts for 42% of weakness amongst patients in the surgical and medical ICU setting. And the most important risk factor is the use of IV corticosteroid and neuromuscular blocking agents. Pathogenesis: myosin loss and muscle fiber necrosis contribute to persisting weakness. Myosin loss is characteristic of critical illness myopathy. Steroids often cause the loss of myosin. Metabolic acidosis and multi-organ failure can also develop CIM. Acidosis may stimulate glucocorticoid production, increase muscle protein degradation, and trigger thick filaments loss. Inflammation, immobilization, endocrine stress response, mitochondrial dysfunction, nutritional deficits, and compromise in the microcirculation of the muscle tissues can also cause impaired protein synthesis. Coming to lab studies. Serum creatinine kinase level If elevated, usually helps to support the diagnosis of myopathy as the cause of weakness in an ICU patient. EMG studies, motor responses are typically low amplitude or absent. The motor response durations are commonly increased substantially, an important clue to the presence of CIM. Slowing of muscle fiber conduction velocity and reduced excitability of the sarcolemmal membrane is often seen. By contrast, sensory responses are relatively preserved, with amplitudes that are more than 80% of normal in two or more of the nerves. Patients with critical illness myopathy demonstrated by direct muscle stimulation may have electrical inexcitability of the muscle membrane caused by myopathy. In clinical practice, stimulation of the anterior tibial muscle and the peroneal nerve at the fibular head can be informative. In critical illness myopathy, the ratio of amplitude of muscle response to the peroneal nerve stimulation is more than 0.5 and often nearly the same as with direct anterior tibial muscle stimulation evoked response. Muscle biopsy, muscle fiber atrophy, particularly involving the type 2 fibers, a variable degree of muscle fiber necrosis with absence of any inflammatory cells is observed in muscle biopsy in CIM. Another important diagnostic ancillary tool is muscle ultrasound. Here, rectus femoris cross-sectional area and quadriceps thickness is measured along with measure of the strength and function of the muscle. Both 5 to 10 megahertz linear probe and 2 to 5 megahertz of curvilinear probe can be used. Sight 2/3 of the distance of anterior superior iliac spine and superior patellar border. Transducer is placed perpendicular to the long axis of the thigh. At this site, with slight pressure at first, rectus femoris is visualized. Cross-sectional area taken by the pallimetric technique, and then quadriceps thickness is assessed and measured. Among these two, rectus femoris cross-sectional area, rate of change from day of admission to 7th day roughly correlates with reducing muscle strength. Treatment. The treatment of CIM is symptomatic, treating the underlying systemic illness and discontinuing or minimizing corticosteroids and neuromuscular blocking agents to the extent possible. Outcome: when the patient survives the systemic illness, recovery occurs over weeks to months, depending on the severity of the myopathy. For patients whose disease severity was pronounced and for those with concomitant critical illness polyneuropathy, recovery is expected to take many months, along with the need for tracheostomy and long-term ventilatory support. The next topic, critical illness polyneuropathy. Patients with critical illness polyneuropathy, they develop a symmetrical sensory motor axon loss polyneuropathy, most prominent in the lower extremities with depressed or absent reflective. In most of the cases of CIP, distal muscles are affected more than proximal muscles. There is usually distal sensory loss of pain, temperature, and vibration sense in patients. Sepsis and multi-organ failure are the main risk factors for CIP. 50% of patients admitted to ICU with sepsis and multi-organ failure for at least 2 weeks will have EMG evidence for an axon loss polyneuropathy. Pathophysiology of CIP-NM is impaired microcirculation causing reduced nerve perfusion, edema, hypoxia, and breakdown in the blood-nerve barrier, damage from cytokines, insulin resistance causing hyperglycemia with damage to mitochondria, abnormal nerve excitability caused by sodium channel inactivation. EMG studies, axonal polyneuropathy with reduced and in severe cases absent sensory and motor responses. Nerves of the lower limbs are often more affected than those of the arms. Nerve conduction velocities are generally normal or only mildly reduced. The ratio of the amplitude of nerve stimulation evoked muscle response compared to direct muscle stimulation evoked responses less than 0.5. Muscle shows atrophy of both type 1 and type 2 fibers. Treatment symptomatic and supportive with stabilization of the critical medical and surgical conditions and vigorous treatment of sepsis. So what are the diagnostic criteria for CIP-NM? Major features: setting of critical illness, particularly if complicated by sepsis, multi-organ failure, and the systemic inflammatory response syndrome, SARS. Difficulty weaning from ventilator that is not related to cardiopulmonary causes, possible limb weakness, electrophysiologic evidence of axonal motor and sensory polyneuropathy. Features favoring the diagnosis are sensory and motor nerve amplitude less than 80% of the lower limit of normal in 2 or more nerves or nerve conduction studies, absence of conduction block or prolongation of the F waves. Needle EMG with reduced recruitment of normal motor unit potentials, followed by fibrillation potentials and reduced recruitment of long duration, high amplitude motor unit potentials. Absence of a decremental response on the repetitive nerve stimulation. Supportive features are normal CSF as well as normal serum creatinine kinase. So that was all about today's discussion. The MRC, that is Medical Research Council sum score less than 48 noted in more than equal to 2 occasions. What is it? True or false? Anyone?
True, ma'am.
True. Okay, so that is right. MRC sum score, this is a bedside clinical scoring system. Okay, this usually assesses the muscle pairs of both the upper and lower limbs. So here actually 12 joints groups are considered. So each is scored from 0 to 5, right? So 12 into 5, maximum score is 60. If the MRC sum score is less than 48, we say that it is suggestive of ICU acquired weakness. Okay. Next option, dependence on mechanical ventilation. True, false? ICU acquired weakness, dependence on mechanical ventilation.
True, madam. True, ma'am.
True, true. Obviously,
True.
if there is ICU acquired weakness because of muscle weakness, there is difficulty in weaning, though no cardiopulmonary causes are present, and hence increased mechanical ventilation days occurs. Okay?
Yes.
So, true, false, true, true. Excellent. Last question. Following are true for management and prognosis of ICU acquired weakness. Option A, incidence may be lowered by electrical muscle stimulation. Option B, a higher mortality has been noted in patients of severe acute asthma who develop ICU acquired weakness. Option C, complete functional recovery occurs in all patients. Option D, in-hospital mortality is around 45%. Okay, so first option, option A, incidence may be lowered by electrical muscle stimulation. True or false?
True, ma'am.
True, very true. Okay, so there was a study, though it was a small study, it was published in the Journal of Critical Care in 2010. It showed that electrical stimulus applied to lower limb reduced the incidence of ICU acquired weakness. Good. Who answered this?
Farhad.
Okay, Farhad, great. Now, option B. What about option B?
Maybe true, ma'am.
No, option B is actually false. Actually, what happens is that a reduced mortality rate of around 10 to 11% again has been found in patients with acute severe asthma. Okay, so mortality rate is actually found to be reduced in patients with acute asthma who develop ICU acquired weakness. Option C. What about option C? Complete functional recovery occurs in all patients. True, false?
False.
Absolutely false. Okay, so we saw this in the slide, right? We saw that complete recovery occurs in only 65% of patients. Achha, next option, in hospital mortality around 45%. True, false?
False.
No, it is true. Okay, so almost 45% of patients die before hospital discharge and another 20% within 1 year. So the answer would be true, false, false, true, right? So that was all. Thank you for your patient listening and also for your active participation. So wish you all the best for your upcoming exams. And I hope this session would be helpful for you. If any help or further clarification is required regarding this topic, I'm always there. Okay, so nice delivering this lecture. Okay then, Deep.
Yes, ma'am.
Are you there?
Yes, ma'am, I am. So
So,
one last
yeah.
request from the participants, if they have any queries, feel free to ask Dr. Bose. We'll take a couple of minutes. If not, we will conclude this session.